Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. It is the last Tuesday of February, which means that this is Top 10 Tuesday, and I have a really good show for you today. So we want to get into some of the questions that have come up with the 2021 E&M. There's a lot of confusion out there still, and so I'm still clarifying questions. There's also some questions on how to code for certain screening services and also when to use an ABN. And so there's a lot of fun today we're going to have with our Top 10 Tuesday. First, I wanted to give a shout out to a couple of people. So I wanted to say thank you to Lourdes, and actually the call sign is T-Girl, to Peyton, to Tara, to Goldie, to Amber, and to Laura H. First of all, I just love you guys, all of you, especially those of you that are very much my supporters of the Codecast. And get the fact that when I comment on the current political administration, that it's more about the policies and things that are happening in the industry. And even if I throw in a couple of my personal opinions, that you realize that this is also a freedom of speech platform. So I just want to thank you for having my back and for posting some awesome reviews and ratings on Apple for me. Thank you. Because I had a couple that decided they were going to post something that was negative because, again, just about politics. So I appreciate you understanding what I'm doing here with the Codecast podcast and really out there just trying to pay it forward, trying to help people on a free platform that gives you information that you don't have to go and pay for. So in saying that, let's take a look at Top 10 Tuesday today. And first of all, one of the questions that have come up under the 2021, and this actually I thought was a really good question. It has to do with the external provider that your physician may be talking to, where you can get a credit under the data points for that. And basically it says a discussion or management of a test interpretation with an external physician or other qualified healthcare professional that you're not separately reporting. And it's under the high and the moderate category 3. And so what does that mean exactly? Well, it means that you actually got on the phone, took your time during that either face-to-face or same-day encounter, non-face-to-face with that patient, and you're basically talking to that other provider, which would be either another physician or an NP or PA, somebody who can bill directly to the payer. Well, here's a question that has come up, and this was, what if we just send a note to a physician who requests it? Or what if we have the Epic drop-down, that's the digital platform, where we have an exchange of ideas or an exchange of information with another physician that can see something that we're posting? Can we bill that, or actually, can we use that as one of our elements for our data points? And the answer is actually no. So AMA actually addressed it, and here's what they said, and I'm going to quote: simply sending a copy of the result directly or entering into the records and shared by another is not a discussion, and is not considered a back and forth discussion to address a provider's question. So the spirit, I guess, of the rule is that they want to see more of a conversation. So a verbal conversation, a phone call, a FaceTime call, whatever. So keep that in mind, that you make sure you're not counting that if you are using medical decision making. So a question comes up, what is the code for smoking cessation and how do we bill for that? So your codes are 99406 to 99407. They're time-based codes. They're worth anywhere from $28 to $52 depending on the payer. Medicare does pay for them, but there are documentation rules, there are frequency guidelines, and there are qualifiers as far as what diagnosis you have to use, starting with the F12 diagnoses. You also have something with the documentation called the 5 A's, which means assess, advise, agree, assist, and arrange. So and that means the patient's agreeing to change their behavior. So make sure that you actually Google that and find your smoking cessation information before you move forward and try to bill for it, in addition to an office visit, because it is billable. You just have to make sure that it's appropriate. Number 3, what question was obesity and weight counseling. Can we code for this? So yes, there is a national coding determination. So a policy for it for Medicare, worth between $25 and $30, again, based on your location. Now, remember, when I throw out a G code, a G means temporary. So it means they're tracking you. And so if you're coding for it, you have to make sure that you are compliant. So there is a BMI qualifier for this counseling, and there's also frequency rules. The G code is G0447, the national determination. So the coverage determination is R142. Make sure you look that up so that you can find how to code for that. There are rules for that. Question 4, depression screening. How do we code for that? That's G0444. It's annually, it's about 15 minutes, and there are, again, qualifiers. Now, I'm going to keep saying that when it comes to screening, because you can't just say, I'm going to give everybody screening. The other thing is when I talk about frequency guidelines, remember, frequency means how many times the patient can have it per year, not how many times your doctor can perform it. That's a really big one, because the doctors will see, let's say that you can have 8 of something, and they'll say, well, I only had 4. Why am I getting denials? Try to appeal it, when maybe their primary care doctor tried to code for it or their cardiologist tried to code for it. And so it's per patient, not necessarily per physician. And you would find that under the MedLearn Matters article 7637. That's for depression screening. What about alcohol misuse screening? There's also alcohol counseling. So it works in a couple of different ways, where you can bill for the G0442 for the misuse screening. And there's rules on that, so make sure you look that up. And then if there's a positive in the screening, then you can qualify for the actual abuse counseling of alcohol. Now, it's in the primary care setting, so you don't really have an option to bill it in other settings, because they're really specific about that when it comes to these screening codes. There are definitely time thresholds there, 15 minutes. You know, Medicare says primary care, meaning general practice, family practice, internal medicine, etc. Also, it is bundled into office visit codes unless you use a 25 modifier, and you use it on the G0442 code, not on the actual office visit, which I was surprised, and that's to bill it on the same day as an office visit. Now, that code is not bundled into the Welcome to Medicare service or the initial or subsequent annual well visit, which I was surprised. And only one diagnosis code will cover it, and that's the Z13.39 for the mental health screening examination for behavioral disorders. There's no deductible or copay, but there are, again, qualifiers on who can actually have that service. Now, let's say that the patient was positive for misuse, and you've already billed the G0442. Well, then it says if those patterns of consumption, if they don't meet the criteria for alcohol dependence, but whose levels, again, positive for misuse and your doctor's concerned, now this patient needs to be counseled. And that means the patient must be alert and competent when the counseling is provided. Again, qualified must be in a primary care setting. And then this would be the G0443 code. So, and then the 5 A's also apply to a lot of these screening codes, and this is one of them. So make sure that you're also looking those up. You can Google anything, and then you go and find the correct information from your national coverage determination. Question has come up of when to use an ABN. Now, what is an ABN? So an ABN is an advanced beneficiary notice of non-coverage for that encounter. Now, these are worth every penny that it saves your physician, because ABNs can help recoup money, especially when there's an assumption that something's going to be covered. But it's really an alert to the patient that something may not be covered at this time for a specific reason. So let's say that that the patient has a statutorily excluded service, then you don't have to issue an ABN, because there's an expectation, or it should be one, to the beneficiary that there's a limitation in their coverage, and so there's nothing that's going to be reimbursed no matter what you do. But here's an example of an ABN where it's required. So let's say you've got a 75-year-old female patient, Medicare patient, that comes in for a screening pelvic exam and a pap smear. The patient states that she's unsure when her last screening was and pap smear were performed. After review of the patient's record, it's determined that they were performed about a year and a half ago. The patient does not meet the high-risk criteria, which creates a Medicare coverage limitation, but the patient still wants it because Medicare covers one screening every 24 months for all asymptomatic Medicare female beneficiaries. Coverages increases to 12 months, once every 12 months, if they have high risk for developing cervical cancer, vaginal cancer, etc. And so if the patient isn't a high risk, now you have to make sure that you have an ABN. So that would be appropriate. Another example would be when it's not appropriate, or I should say not medically necessary. So let's say you have another 75-year-old female Medicare patient requests a removal of a skin tag on her neck. The skin tag is deemed to be benign in nature. It's not inflamed. It's not bleeding. It's not itching. There's nothing there. It's just cosmetic. The patient's request to remove it creates a Medicare coverage limitation because, again, Medicare doesn't cover benign lesion removal for including skin tags for purely cosmetic purposes. So unless there's some kind of a sign or symptom that reflects inflamed, bleeding, itching, etc., then you would have to have an ABN signed. And so just make sure that you know when it's appropriate, when it isn't, and that it has to be something that is following that patient for at least a year. Otherwise, there could be some issues there. But that's a really big one when it comes to the ABN. So how to code for a cast removal. This came up recently. It says when our provider removes a cast from a patient, boot, body, full arm, leg, or shoulder, hip, etc., can we report a CPT procedure code for the procedure removal, or can we just code an office visit code? So you cannot report an E&M service for this, but there are circumstances where you may be able to report cast removal codes, which start at the 297,000 or 700 code series, 29700 to 29710. And this is when the cast was placed or applied by another individual. So let's say that the patient reports for a full leg cast removal. They went, skiing on vacation. They sustained an injury to their leg or broke their leg. And now they're coming back home to their primary care doctor, the orthopedic physician, and they're here to get it off. So that would be the 29705 for the removal, which basically says that's the removal or bivalving of the full arm or full leg cast. And that also indicates that you did not perform the initial casting. I would also probably put the laterality modifier on it, right or left side, to indicate, what side it was, just so you can get paid for that. But it's not an E&M service, okay? So just know that it's part of a global surgery package, and that's why you do have some, options procedurally if you are not the provider who put it on. Now, here is an interesting question for my primary care and cardiology people out there. Our provider recently documented a patient as having both type 1 and type 2 diabetes. I've heard of this being called diabetes 1.5, but I can't find an ICD-10-CM code for it. What do I code for that? Okay. So diabetes 1.5, also known as latent autoimmune diabetes in adults, LADA. This is a condition that has characteristics of type 2 diabetes, such as adult onset and resistance to or deficiency of insulin, but that is more closely related to type 1 due to its autoimmunity to certain antibodies and to the patient's low BMI. So due to the fact that this type, and I'm just going to call it LADA, is a specific form of diabetes, I would probably look to the codes E13 section, because according to the AHA coding clinic, and this was on volume 5, number 3 in 2018, they recommended E13.65, other specified diabetes DM with hyperglycemia, as hyperglycemia would be the most common complication from the condition. So that's what I would code, but it just depends on how well your physician had documented. So Swan, Gans versus right heart cath, that is a question that comes up all the time. So the same type of flow-directed catheter is used in both procedures, but for those of you struggling to know if you did a diagnostic right heart cath 93451, 26 modifier if you aren't in your own cath lab, or Swan Gans catheter placement for a critically ill patient that you're monitoring hemodynamics, that's 93503 with no modifier. There's a big difference in reimbursement. The 9345126 is anywhere from about $150 to $225, and the 93503 no modifier is about $400. So that's a big deal if you want to know what you're doing. Here's what you're looking for. You're looking for the Swan because that's same type of catheter. But if they leave it in, it's a Swan. So if they leave it in and it's typically done at bedside, that's the 93503. If it's looking at really pulmonary function, right heart, which is lung area of the heart, and then maybe they might do an injection or not, but then they take it out. So they're really measuring pressures. You'll see RA pressures. And they take it out and they're done. So the patient then leaves the cath lab. That's 93451 of the 26. That's diagnostic. Okay, so there's a difference there. And then number 10 in our top 10 Tuesday, I had a question come in. Now I'm only laughing because I just thought it was funny. It said contact with, Terry, how do I code for somebody who burned their mouth with hot sauce? And I'm like, oh, I love hot sauce. Tapatio is my favorite, but okay. So they wanted to code injury. It said food injury, which is T78, and then you'd need 3 other digits, so 0.0XX or whatever. And I'm not comfortable with that because that's a anaphylactic food allergy. So basically, you're going to need your EpiPen. You're going into a major problem there. I would code actually X10, so X10.1 XXA for initial encounter. That's contact with hot food. Now, there is nothing for spicy food, only hot food, and I know it infers that it's probably the heat, and that's how you burned your lip, but because it doesn't clarify, I would use it. So for me, it would be the X10.1 XXA. I just wouldn't want to give somebody anaphylactic allergy if they didn't have it. So that's a really big deal. Okay, so hopefully those were kind of a mixed bag of helpfulness today when we talk about certain coding situations. And to end, I just really wanted to send our thoughts and prayers to the people of Houston and a lot of the areas around Texas and that area for the snowstorm that they've had these past 6 days, and the freezing temperatures, the lack of food, water, and electricity, and I just can't even imagine what you're all going through. So if you can do anything out there, people, to really help them, anything you can do, there's donations set up. All you have to do is go on social media or, Google it and figure out how you can give back, even dropping off some warm clothing or anything. I'm sure that everyone would appreciate it. And if you have bottled water that you can spare, anything that would really help out there. If you have friends that are there and they've got a Cash App and you can give them a little bit of money just so that, when things open up, that they can get out of their place and go get some water, that would be great. So anyway, I really hope you're safe. Hope that your electricity gets on soon. And just know that we are thinking about you here at the Codecast Podcast. All right, everybody, make it a great day and a great rest of your week. And thank you for listening to the Codecast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Cessation Music.